So I want to go back to Heather because Dr. Herbst brought up, kind of just give us some sense of the difference between first, second, third generation inhibitors, and then let's talk a little bit about the data in the third generation, specifically as it pertains to T790M.
Sure. So one can define that slightly differently, but I think it really has to do with the targets. The first generation EGFR TKIs are hitting wild type as well as the sensitive mutants, but they're not really getting T790M. The second generations, and really afatinib is the one that would really put in that group, has some activity against T790M, but is still far more potent against the standard sensitizing mutations. With the third generations, you're bringing in increased sensitivity to the T790M as well as to the standard mutations, but not so much to wild type. And so it's really the sort of the potency for the different types of EGFR that defines the first, second, and third generation. So at this point, we don't have any approved third generation drugs. We've got two that are in pretty advanced trials at this time into phase 3, and that's the AZD9291 and CO1686, also known as ruxolitinib. And both of those drugs have, we've had updates annually, and actually more than annually at various meetings, both in the US and Europe and Asia now as well, showing significant activity, more so in the T790M secondary resistance than in patients who have other mechanisms of resistance. So both of those drugs, the AZD9291 and ruxolitinib, the first trials were for patients who had been doing well on an EGFR TKI and then became resistant. And in both groups, both the trials, there was selection for T790M or other mechanisms of resistance. The trials have now kind of moved more towards the T790M population, but we have data for both plus and minus T790M. And for both drugs, the responses with the T790M is somewhere in the 60% range, depending on which update you look at. It kind of fluctuates between 50, 60, but somewhere in that range. And for those who don't have T790M as the resistance mechanism, the responses are in the 20 to 30% range. So they're still working, right, even without T790M, so for those other mechanisms of resistance, but they're working better when you've got T790M, which makes sense. And it sounds like Anne has a comment.
Yeah, so Mark, I think the critical thing is there's enormous enthusiasm for these third generation inhibitors, and they both have FDA breakthrough designation. So we're really looking forward to hopefully getting these out of trial and into the commercial use for our patients.
Right.
So it's very relevant, I think, the discussion about whether these go to frontline for our patients.
Right, and that's where the trials are right now. I mean, they're first-line trials with both of those. They're second-line trials versus chemo. And
I mean, I understand that sentiment. However, I also think that there may be a role for first or second generation TKIs. A patient may get 2 or 3 years of very good disease control, and then this could be a good option if they develop T790. They may be another 2 or 3 years on the drug. So the reality of really making this a much more chronic disease with oral therapy, perhaps they'll be better in the first line setting, maybe less toxic, but I think we have some questions about sequencing and when, that's a sort of issue.
And that'll come up when we talk about ALK also. I mean, it's really that question of are the second and third generations, if they're going to work this long, is that better than your first generation followed by your second or third? And those are questions we don't know the answers to yet.
Sure, and I think the toxicity discussion, though, has to also factor in. Because since these third generation inhibitors are targeting mutant EGFR, they don't necessarily hit and give the patients as bad diarrhea. The rash is certainly less. And so I think that quality of life has to factor in, because again, we're not curing these patients.
And getting back to Roy's point is, maybe others on the panel have, but I've not seen any data on rebiopsies of patients that are resistant to the third generation agents and what that may.
Right, we're beginning to do some of that, and you do see different mutations.
Right.
And I think what you mentioned is just so interesting, how you sequence these agents. Because I've heard physicians say, oh, well, if I give my best drug up front and then they become resistant, what do I do next?
Right.
Now, there will be new drugs at some point,
right.
But the question is, do you actually get longer progression-free survival that way, rather than, as you say, starting with the more standard drugs? I think we need to do trials, and these trials need to include biopsies as well.
I think the session we